Hello and good evening, everyone, to Uromet number 20. And so today we have another very interesting session on BPH and andrology, and two eminent examiners and eminent urologists will be doing the mock vivas, and it will be Professor Majid Pavlasekara and Dr. Niroshan Seniviratna who will take the vivas uh, um, today. So I think Prof. Ajit Pavlasekara, sir, are you there, sir?
Hello, Tilina. Yes,
Yes,
I'm here. I'm logged in.
yes,
Yes.
yes, sir. So I think as Prof. Pavlasekara mentioned, he's going to do a little bit of a uh, one viva without actually timing, and then I think you're going to move on and do the similar or same viva in a timed manner. So I think that is just to highlight the importance of timing and how well, I mean, how we have to allocate the time according to the questions and move on quickly. So without any further delays, I will hand over the um, video feed to Prof. Malvasekar. So you can tell what exactly you're planning to do. And the first candidate is going to be Dr. Nishant Veerasinghe.
Good evening, sir.
Hello, Nishanta. So I'm just going to share my screen. Can you see this?
Yes, sir.
Yes,
Yeah.
sir.
Should I? Is that better?
Yeah.
Yeah. Okay. So these are few basic topics on andrology. Three areas that I've just picked out. We'll leisurely take one of the topics and discuss it. I will ask the questions and you can answer me. And then as Tilina and I discussed, I think one of the important things is to run through these questions so that you get to the almost the final question so that you can score more at a particular viva. So I think that may be because now you all are sort of experts on topic wise. So I think it is a good thing to get to speed with the viva itself. So we will do a few trial runs with this. So let's start off with the first one. So you will be seeing it like this on the computer screen in front of you at the exam also. So 29-year-old man married for 1.5 years presents with concerns regarding inability to have a child. Now, what is the general recommendation with regard to timing for patients to seek help in regard to male infertility?
Timing is for 2 years after unprotected regular sexual activity in couple, inability to unable to achieve pregnancy during that 12 months. Sorry, 12 months. Sir. Sorry, I mentioned it wrong.
12 months. Okay,
yeah.
fine. Then, this patient, 29-year-old man, married 1.5 years. How will you clinically evaluate this patient? This patient is at your clinic. Let us know how you evaluate this patient.
I would like to get the patient and the partner to the my clinic. And
Both they are in front of you.
Sorry, history-wise, I would check whether they have had a regular unprotected sex, whether they have any used any spermicides or like those things. And I would check the patient's erectile function. And I will also check the patient's developmental history to see whether there is any history of cryptorchidism, torsion of testis, any inguinal portal surgeries, and history of trauma to the testis, and diabetes, lifestyle of the patient, and whether the partner has checked. And then on examination with the chaperone, I will examine the patient's body mass index, the secondary sexual characteristic, thyroid status, and abdominal examination, the scars and the genitalia, the penis examination, deformities, the prepuce and the meatus. And I would examine the testes, the consistency, size, and whether they are in presence of varicocele or the bilateral presence of bilateral vas, and examination of the digital rectal examination of the prostate, as well as brief neurological examination. And after that, I would go ahead with the seminal fluid assessment. I would need 2 samples.
Okay. So this is the seminal fluid sample that he provides to you. What do you think? What is your opinion on this?
The volume is 2.5 is adequate. pH is more 8. It is more than normal. The concentration is the patient is having oligospermia, so the concentration is low, and the oligoasthenospermia morphology is normal.
Right. Okay. So what other tests would you request from this patient?
I would like the blood test of morning testosterone, FSH and LH.
Right. Okay. So those are the basic tests that you would FSH, LH, and testosterone you mentioned. No? Any
Yes,
other tests that you would think of?
At this stage, I would not go into detail, but the other things that I can check is if concerned is the karyotyping and genetic assessment.
Sure.
Yeah,
is that indicated? Now, let me show you this. Do you know what are the cutoff marks to indicate that we should do karyotype?
Those things are especially for severe oligospermia and
how will you define how will you define a severe?
The count less than 5 million.
Right. Okay. So these are the hormonal tests that are provided to you. What do you think?
His serum testosterone is low. FSH, LH, I'm not 100% sure with the normal values. So it's likely this patient is having hypogonadism. It could be primary or secondary. Unfortunately, I'm not 100% sure whether it is FSH, LH, normal or elevated.
Right. Okay. So So what else would you want to do in any other tests that you would want to request beyond this?
So
let's move on. Right. Let's move on. Yeah. So he also had an ultrasound scan of the scrotum. What do you think?
There is small left testis compared to the right side, and there is grade 2 left varicocele. So this patient has the symptomatic left varicocele because patient has oligospermia, and then there is a testosterone value also low. But in this condition, problem is if he treat with testosterone, his fertility will further go down. So I would recommend doing left varicocelectomy and see.
What is your evidence-based recommendation? What is the evidence to say that this man needs a varicocelectomy? What are the criteria you can pick out and apply to this man?
Criteria for varicocelectomy is the clinical grade 3 varicocele, the patient's any symptoms, the presence of hypogonadism or subfertility in the presence of varicocele.
Okay, so he has subfertility, and as you said, the clinical, you examine and say that there is a grade 2 or 3 varicocele. Then what else did you mention?
For the assessment, or
No, for recommending a varicocelectomy.
Clinical
What are the?
grade.
Yeah,
Clinical
okay,
varicocele,
that's right. You mentioned that.
pain,
Pain. Okay.
pain, and so it is not related to this thing, the general, and then
Right. No, we are talking about this particular patient. From evidence, why are you recommending a varicocelectomy in this particular patient?
this patient has a oligospermia.
Yes. Okay. So the sperm counts are abnormal. Fine.
Yeah, and so varicocele.
Okay. So are you happy with the ultrasound finding of the varicocele, or what will you say?
Small testis on the left side.
Right. Okay. Fine. So what are the options you can offer this patient?
There are several options of varicocelectomy. There could be minimal invasive and surgical intervention. Minimal invasive is the
Nishant, are you breaking up, or is it me? My connection?
I think his connection is little.
Right. Okay. Fine. Fine. Yeah.
Yeah, I switched off the video.
All right. Now that's better, Nishant. Yes. So why don't you start from the options? Yeah. Why don't you start from the options? Yeah.
Yeah. So there are several options: minimal invasive and surgical interventions. Minimal invasive is the radiological embolization of the spermatic vein, laparoscopic ligation or clipping of the spermatic vein, and the inguinal open approach, where we can do with the microscopy or with the help of loop, so we can ligate the spermatic vessels, and scrotal approach, which is high risk for the testicular atrophy. So I personally used to do the inguinal approach, which has a high success rate and a lower recurrence rate.
Right. So how will you consent this man for this procedure? Briefly, how will you consent him?
I would explain to him this: the oligospermia is likely to be due to this varicocele. It has shown that in some patient with clinical varicocele oligospermia, after correction, there is a chance that 30% improvement of having a pregnancy, and a small chance during the surgery there will be damage to the testicular vessels, causing
what
testicular atrophy.
Percentage of would you say?
I would say less than 5%. And the other common complications, bleeding, infection, and numbness at the groin, those things.
Right. Anything in the procedure briefly that, yeah, what is the sort of the accepted surgical intervention wise? What is the sort of preferred method nowadays?
Sorry, should be done under microscopy.
Right. Okay.
So
yeah.
Once the patient consented and anesthetized, I would do the left inguinal approach. Sorry, inguinal crease incision, and then I would inside the external oblique and deliver the spermatic cord. And then under microscopic guidance, I would identify the spermatic vessels.
So you mentioned, you mentioned, so spermatic veins from the most important crucial artery. Any specific methods that could help you?
Then I can see the intraoperative Doppler to see, identify
Okay.
the, and then I will need to preserve the lymphatics as well to prevent the hydrocele formation.
Good. Any other sort of medicinal things that may be helpful to identify the arteries or?
I think papaverine, then antispasmodic, that can help here.
Fine. Okay. So yeah, so that's fine. Okay. That's Nishant, that was I think pretty comprehensive, even with the poor connectivity. We've only gone to about 11 minutes, so roughly about 10 minutes, let's say, right? So I think if we go back on these, generally my plan was that this first question should be about 30 seconds, right? Can anybody provide it? So you mentioned that it is 12 months duration in a young man when they should, following regular sexual intercourse, when they should come and seek help. Anybody else can mention any other criterion? Is it 12 months the recommended for everybody, or?
I think if the couple is elderly or the female partner, then they can, even 6 months is okay, I think.
That's right, absolutely right. Yes, so yes. So that it should be just 30 seconds. And then I probably allowed about 2.5 minutes for this question. And I think Nishant kind of covered all these things. So maybe a little bit about the previous, the fertility history itself, I mean, asking about whether their first marriages, maybe the wife has had a previous marriage or even some abortions, etc. Those kind of things may be relevant as well. Then you mentioned about the sexual history. Then the other component, 2 components are the medical history, and things like mumps, orchitis, etc. may be relevant to mention. I mean, hypogonadotrophic hypogonadism. Can you elicit that in a just by asking one question, maybe whether there is some presence of it? Anybody?
Whether the patient had a pituitary surgery or radiotherapy.
Okay, yes. So, or anosmia in relation. What? Yeah. Kalman syndrome, hypogonadotrophic hypogonadism. Yeah, okay. So, I mean, just to show off your knowledge and just get some marks, right? So that's there, medical history. Then moving on to surgical history, you very correctly mentioned about torsion, orchidopexy, etc., and maybe these things. Then other aspects of gonadotoxics, right? Even some radiotherapy or chemotherapy, etc. I mean, you can mention. So those are the kind of sort of categories you can sort of mention in these people, and past history of any treatments, any evaluations done would be useful. Then about the SFA, you were spot on. I mean, I think everything. If you can just mention the WHO manual, right? As per the WHO manual. Anybody knows the latest edition, the number? It's the 5th edition. That's the latest one. So, again, you can just show off your knowledge and just say, just quote, say the WHO manual for, in the laboratory manual for the processing of these sperm samples. Okay. So this was again about 45 minutes, and the hormonal tests, generally serum testosterone, prolactin or FSH are the 2 main ones that are the required ones. Beyond that, prolactin, LH, estradiol, TSH, etc. we will do if there are any suspicions. So actually, I should have given you probably the normal values, but the 3 is the cutoff mark for serum testosterone, FSH, LH. It's 2 to 8 is normal, and prolactin up to 20 is is normal. So this is only marginally high. So just have a remember these. Varicoceles, actually more than an ultrasound identified varicocele, what they say is that it should be a clinically identified varicocele with SFA, a proven abnormality. That is the indication for varicocelectomy. The other factors, the testicular size being low, yes, especially in adolescents, less than more than 20% reduction in size, and soft testes, hypogonadism also can add on weight, but the evidence-based ones are those two, right? Then in this, I think you went through most of them pretty well. Anything about the consent, any other things that you can mention? Yes, you very correctly identified about the arterial injury less than 1% or even less. Any other things that you mentioned which can differentiate microsurgical versus the other interventions? What are the advantages of microscopy use compared to the other, even laparoscopy or robotic assisted or Palomos, etc.? What are the advantages?
It has shown that a higher chance of success. I think 39 or something like that. And then recurrence rates are very minimal compared to others.
That's right. Actually, I think, correct me if I'm wrong, but if you look at most of the Cochrane reviews and all the meta-analyses, there is no evidence saying that one procedure is advantageous over the other as far as pregnancy rates, etc. are concerned. So laparoscopy, etc., microscopy, all will have the same outcomes, in a sense, the success rates, but the recurrence rates and the danger of having a hydrocele post-procedure, the best outcomes are with microsurgical subinguinal varicocelectomy. So that is correct. So I think those are sort of the kind of the things. So I left about 2.5 minutes for this. This I would have given only about 30 seconds just to say evidence-based. These are the factors to go ahead and do a varicocelectomy. This again maybe about a minute, half a minute. This about a minute, and this maybe 2 minutes, and this would just take 30 seconds. So I think the one that would be challenging is this question, and I think Nishanta tackled it very well, going through most of the categories. So you have to look at the previous fertility history, then the sexual history, medical, surgical history, and then sort of, and the, you carry on with, and the etiology factors, etc. And then move on. Mention something from each of these categories so that the examiner can tick you and give you marks and move on to the next one. Anything else that you all can contribute, or Balagobi, anything that you can chip in?
Yes, sir, you have covered almost everything, sir. Yeah, that's very nice. We can move to the next one.
I think we will have a very nice review on microscopic inguinal varicocelectomy coming in the Sri Lanka Journal of Surgery very soon. So maybe after the exam, you can enjoy it from one of our urologists. So
yes,
next question.
Shall we do alternatively, and shall we move on to Dr. Niroshan Senevrat?
All right. Yeah, sure.
All right.
Or if Niroshan is happy for me to finish, I don't mind finishing. Is that all right?
Whatever, sir. It's up to you.
Yeah. While my PowerPoint and everything is there, can I finish off then?
All right. Okay. Right. Next candidate is going to be Dr. Nishantan. So over to you, sir.
Hello, Nishantan. So so this is a 45-year-old diabetic who has hypertension also, who's unable to have penetrative sex for 6 months, has tried, he mentioned he has tried Viagra with poor results. So how will you define erectile dysfunction?
Definition wise, if he it depends on the patient whether he can't achieve a adequate erection to have penetrative sex, that is considered as erectile dysfunction. Then to validate that, there are further questionnaires are there, so we can have the definition.
What is the pathophysiological mechanisms in this man?
Normally the pathophysiology is either it could be a vascular cause or neurological cause or combined causes. So in this patient, since he is for age is relatively young, 45 years old, but he has diabetes and hypertension. So that might be the reason where the vascular cause as well as diabetes, where the mixed patterns are there. If it is having uncontrolled diabetes, then both factors might be there, vascular as well as the neurological part. And,
okay. So move on to how he's in front of your at your clinic. How will you evaluate this chap?
Evaluation will include the history and examination, and also there will be a validated questionnaire in international II in erectile function questionnaire short form.
So briefly the history and the examination. Just a couple of
history.
minutes.
I think I wanted to assess the patient with his partner actually, and I will assess how he's saying the erectile dysfunction and what is the time and what about the flexity and fenestration is satisfying, or what is about the quality of life, satisfaction of the partner, and those things. And since he has given already the tablets, one 5-alpha reductase inhibitor, so failed treatment also I will ask. And in the examination, of course, I will assess him. The general examination, are there any neurological disease, evidence of neurological disease, and in the abdominal examination, are there any masses, and in the genital examination, are there any penile deformities or Peyronie's disease? Those things I will evaluate. And also while doing a DRE, I might have a sponges reflex to assess the nerve roots. And also if there's any significant neurological defect, I can assess the lower limb weakness also in this patient. So
right. So investigations wise, what would you like to do?
I wanted to
specific investigations.
Basic investigation include the full blood count, and in this patient specifically the renal function and also diabetic control I will assess. And specifically to have have an idea about the erectile function, to exclude vascular causes, we can go for a penile Doppler ultrasound, or otherwise we can have Doppler ultrasound we can do. And I'm not sure.
Okay, so these are some of the findings that you have. So there's the hormonal profile and some the Doppler post-alprostadil.
Okay. So the volume, I'm not sure about the normal values of testosterone and the prolactin. And,
so these are both normal actually.
Okay. Then the hypogonadism part is unlikely. It's duplex scan findings also correlating with the normal finding, where the weak systolic velocity should be more than 25 and the end diastolic velocity should be less than 5. So that I think correlating. What is
so how will you what will you advise in this man?
So the patient is having since there is no intravascular, part is not there. So managing the disease, controlling his comorbidities, and I wanted to assess about this treatment, previous Viagra treatment. I wanted to assess the adequate dosage was given or not, and also I will assess the patient is are there any contraindication to go for a 5-alpha reductase inhibitors in this patient, whether the patient is on nitrate, so ischemic heart disease, cardiac failure. Those things I wanted to assess, and other tablets he might be taking, which might be affecting the erectile function. So those things also I will assess. and then I will give the maximum dose, and at least I can try, I think, 6 cycles of 5-alpha reductors in adequate doses. If
So
those are failed,
he has tried Viagra with poor results. How will you improve the situation?
that case, as you mentioned, I wanted to assess whether he had adequate dose or not, or if it is failed, then
So he said he had taken 50 milligrams.
So we can even go for a 100 milligram dose. So we can increase
Anything
the
else
dose.
in that the dosing
And
or other matters in the
the
taking
matters
of the
whether
drug?
whether he has taken the drug properly, he might have taken the tablet after having fatty meals and taking with the alpha blockers. Those
Right.
might
Okay.
reduce the effect of the 5-alpha reductase inhibitors.
Right. Okay. So the wife is concerned regarding any cardiac risks, and is pushing to even does he need a cardiac assessment? I mean, is that very logical, or is it just the waste of time? Do you know?
That's true. Normally what they say is if the erectile dysfunction might express more earlier than the cardiovascular diseases. So he might be having underlying some cardiac disease.
What is the underlying pathology at the level?
Atherosclerosis. So there might be cardiovascular, so the atherosclerosis in the heart as well as the brain. So they are more prone to get this.
Right. So you have advised him about the Viagra, etc., but the sildenafil usage, but he comes back to you with poor results, and from the options he is willing to try intracavernosal medication. How will you explain this to him?
Intracavernosal, I think there are intracavernosal injections are there. Prostadil is there, and papaverine also there. Normally, Prostadil is used, and he can use even the transurethral applications, and transdermal applications can be used. Those has a good effect. Since his vascular penile vasculature is okay, it can be given, and but he has to get the injection before having the sexual activity. And also the problem is he might have experienced pain at the site of this one, and later rarely he can have developed the fibrosis. Those are there. If he develop chest pain, then he has to get the medical
Anything after he sort of gets this injection, anything for him to watch out for? Chest pain you mentioned, but anything specifically locally that you should watch out for?
I'm not sure whether he is developing significant swelling and priapism. I'm not sure.
Yes, priapism. Okay, fine. Okay, so yes, Nishanthan, I think the definition, there are other specific things that you need to sort of go through and sort of spell out regarding ED. Now, regarding the pathophysiology, in this man, one of the biggest pathophysiological causes will be, I mean, it is bound to be more organic, possibly primary organic versus primary psychogenic. Now, in organic, you mentioned vascular problem. Anybody knows any sort of key words that you should use about the blood vessels and the dysfunction that takes place? They always speak about commonly in cardiovascular disease and also in ED. What is that common mechanism?
Sclerosis.
Yeah, all these lead to the endothelial dysfunction. That is the sort of the key. Yeah. So, these are things that you should throw off at the examiner so that they also can tick the correct boxes and give you marks, right? So endothelial dysfunction is a crucial factor. That is what, and it is prevalent throughout the body. So that's why you get cardiac problems as well as endothelial dysfunction in the penis also. So evaluation, anything else that anybody can put down? I think things like smoking and other factors like alcohol, in a young man. So these are factors, and also his overall exercise, general health. If the general health is good, then you can expect the sexual health to be good, and vice versa. So you need to find out about smoking, alcohol, and all these habits also. You mentioned about other medical issues, drug intake, etc., and partner issues, etc. also, right? The investigations, yes, the hormonal investigations such as testosterone and prolactin, etc., is important. And the Doppler studies post alprostadil, yes, you can go on to if the initial tests are normal. Now, it's good that you didn't, you tried to mention that you will question the dosages of the Viagra used, how he uses it, because is he using it after a heavy meal? Is it just 1 hour before the activity, etc., etc.? One must clarify the technique, because there's a large percentage of patients who will take the tablet incorrectly and just throw them away, because that becomes a problem, right? So these values do indicate a very marginal arterial insufficiency. So yes, you can be concerned about these cardiac risks. Anybody knows any landmark trials or any consensus papers that have come out with regard to ED and vascular disease? It's a city in the US. The Princeton, sorry?
Is it Nottingham?
Actually, the Princeton consensus, there have been, I think, about 3 consensus statements come around with several endocrinology, cardiovascular, urology, sexual medicine experts getting together. And it's all to do with the cardiac risk. And they grade it down into 3 areas. And they almost say that 45-year-old man if a young man comes with ED without even heart disease, that he should be branded as a cardiac patient until proven otherwise. So that is the Princeton consensus statement. Just again throw this at the examiner just to collect a little bit more points, right? One of the things that you must mention in counseling these patients is about priapism, right? Alprostadil may be about 1% or so, but with papaverine, which we have only have usage of papaverine here, alprostadil very rarely. The instance of priapism is very much more. So you must warn them of prolonged erections and tell them to come back if that takes place. So that must be there in your counseling. And also you can advise them about technique. Anybody knows about the technique itself, about injection? If you look at a clock face of the penile shaft, where do you inject? What do you avoid? Anybody?
Can inject in 3 or 9 o'clock position.
That's right, yeah.
Avoiding vessels and oblique path to the needle to prevent the bleeding.
That's right, because in the 12 o'clock position, you will have dorsally, you have the neurovascular bundle, and inferiorly, you have the urethra. So 3 and 9 o'clock, vertically, if you plunge the needle in, you will get into the corpora cavernosa. Yes, so very quickly you can advise them, and there can be a little bit of pain. So bruising can occur. So once you pull the needle out, just press on it, press at that point and wait. And obviously you need to tell them that you need to do this procedure about 10-15 minutes before the expected action, right? So yeah, so those are the any other comments or anything that we could have done better?
So at what point you do the Doppler scans?
Yes, I mean, initially, actually, they do mention in a young man whose androgenization looks normal on secondary sexual characteristics investigation. It is satisfactory actually to prescribe oral tablets on pure history and examination alone. Maybe even the testosterone and prolactin assessments, there are controversies. You know, the endocrinologist guidelines will tell you that testosterone evaluation is required. But if you look at it, it takes very hypogonadic levels to give ED with hypogonadism. So in a general androgenized man, even the hormonal levels, you can leave for a second aspect. And this alprostadil injection plus the duplex also is not a first line thing. You can, it is justified to clinically treat with oral tablets, and then if they fail at a secondary state in a more specialized center, to go for those further investigations.
So is that was that a place if he has had a pelvic fracture or any history of trauma to go ahead as a first line investigation?
Yes, I think though there are certain sort of flare signs, for example, neurogenic causes, etc. If you pick up any neurogenic things, possible etiologies, and as you correctly mentioned, Nishanta, in a younger patient where you feel that there is a correctable cause, yes, to go in for even angiographic studies, etc. It's very much indicated. Yes. So the history and examination will pick out those patients in whom you can straight away go ahead with treatment without very much investigations, while in another group, you will pick up those who should go to a specialized center to have those particular investigations to be done. Shall we move on to the final one, Tirina?
Sir, about the peak systolic velocity you mentioned in this question, did you expect anything more?
No, actually, I mean, there are certain, the cutoff mark is also, I think it's given as 30 by the, in the Bowes consensus statement, as well as the if you look at the ASRM and the EAU guidelines, all mentioned as 30. So I think this is a patient who has some evidence of arterial a sort of a vasculogenic cause for the erectile dysfunction. So that is what I wanted to pick up. That's all. Yeah. And but he did correctly mention that if it is, some do mention below 5, some mention as below 3 for the diastolic velocity. Yeah. So just as a interpretation, I mean, these are the sort of things that if they can mention, that would be fine. And to mention that basically the hormone levels are normal. And if they mention that there is no major hypogonadism, so that they can proceed with that the usefulness of any testosterone injections is not relevant in this young man. Also, one should remember that diabetics do have a higher chance of having low levels of testosterone also. Yeah. Shall we move on, Tilina?
Yes, sir. So the next candidate is going to be Dr. Taha Mohammed.
So Taha, this is a 50-year-old diabetic who has had intracavernous papaverine. He's had several injections and 30 milligrams on following that. He's having a persistent erection of 3 hours and he's in pain. What is this condition and what is the basic pathophysiology?
The condition is an emergency, which is a priapism. The pathophysiology is in papaverine injection. There is a inhibition of phosphodiesterase 2, 3, 4, and 5, where there is reduced level of intracellular calcium and the smooth muscle relaxation. And there is filling of blood in the cavernosal tissue, which has not been drained. So the cavernosa become rigid and it is causing pain. And because of that, arterial supply to the cavernosal tissue will be reduced.
Right. So quick evaluation of this man.
So this is an emergency. I will see this patient by myself without any delay. So I'll make sure that patient is comfortable. So I'll give adequate analgesia, hydration, and oxygen if needed. And I will take a quick history how it has been. It has started, the onset, whether it is spontaneous or with the sexual stimulation, and then the duration, and the duration is given 3 hours, and whether he had anything during this 3-hour period, any past history, any history of leukemia or any other hematological factors such as sickle cell disease. And then I'll quickly move on to examination, general examination after stabilizing the patient, have a look of the penis to identify the rigidity of the cavernosa, to rule out or to have an idea whether it is low flow or high flow priapism. Right. And then I will take, after ruling out it should be probably a low flow priapism, so I can take blood flow analysis. So that is
okay. So yeah, so you have the sample and the blood gas done on it. What is your interpretation of this?
So I can see the pH is less than 7.2, acidotic, PO2 is less and PCO2 is more. So I suspect low flow or ischemic priapism.
What are the other pictures that you may see in priapism?
So glucose will be low and other in low flow priapism.
Right. In the other type of priapism, what are the
types? High flow priapism and the stuttering priapism, that is recurrent priapism. In high flow, there won't be, because of high flow, the picture will be the vice versa. There's no hypoxia or hypokalemia.
Right. Okay. Fine. So what is your management in this man? You
So
done
initially,
ABG? Yeah. Yeah.
I will aspirate the corpus cavernosa with a large bore cannula, probably 19 gauge cannula through the glans penis. While my target would be aspiration of 200 milliliters of blood, and then see whether the flaccidity comes back. And if that is not the case, I will wash with normal saline, and then I will wait for the flaccidity to come. At the same time, I will make sure the patient get hydration as well as analgesics.
Right. Okay. So if that also doesn't work,
then I will approach this in a stepwise manner. Then I'll go ahead with the sympathomimetic injection. I will prefer phenylephrine, which should be so it comes as 1 milligram per 10 milliliters. So I can inject 250.
Sorry, what was the concentration phenylephrine?
10 milligram in 1 milliliter. So I will dilute,
okay.
And then my target would be 250 or 200 microgram at once in aliquots every 10 to 15 minutes with a maximum dose of 1 milligram. At the same time, I'll make sure the patient is connected to a cardiac monitor, because there may be tachycardia and hypertension, and I'll rule out he doesn't have any contraindications such as MAO inhibitors or malignant hypertension or severe hypertension.
Right. So how long will you keep on going this way?
So
you mentioned that about 200 to 250 aliquots of given every 5 minutes or 5 to 10 minutes is your dosage. So how far will you go?
So maximum is 1 milligram total dose. So over 1 hour, I will inject this aliquots. Right.
Okay. So what are the sort of the endpoints you're looking at?
The flaccidity of the corpus cavernosa.
Yeah.
And
anything about the color of
The aspiration would be, no, I'm not sure.
right? Okay, so so failed aspiration and sympathomimetics, etc. So what next?
Next would be, I can consider shunting procedures, which either can be distal or proximal shunting. Distal shunting, there are options. It can be winter shunting, that is, large needle going through the gland spines into the corpus cavernosa, or Eberhodge, or
Okay,
T
so
shunting.
mention whatever distal shunt you know some details about. Can you mention how will you do it? Are you doing it in the ward or in theaters, or where do you anticipate doing this?
So certain shunt we can do in the A&E or ward setup with the penile block.
Right.
Certain shunt like Algora, like, we have to cut a piece of a corpus cavernosa, which had to be done in the theater. So depending on the type, we can decide whether it can be done in the ward or the theater setup.
Right. Okay. And what any basic steps that you can mention? Yes. Of any of one of these procedures, just pick up and tell me.
Okay, I'll go for T shunt. That is, a scalpel shunt, which after penile block, then I can insert a scalpel on the lateral, avoiding the urethra, and then after that I can turn into 90 degree to make a shunt, a T-shaped cut in both cavernosa through the glands.
Right. Okay. So do you close up, suture up after the procedure, or what do you do?
No, it should not be suture because it should be drained. So I won't suture.
Right. When you say suturing, is it the tunica or the corpora cavernosa or the skin which you are concerned about? Or?
So I would prefer going through the glans penis.
Right.
So I won't suture if needed. I won't suture it.
Right. Okay. So if that fails, any further procedures that you can do?
There are other options like this proximal shunt, but nowadays it is not preferred because high prevalence of erectile dysfunction subsequently. If that is the case, I may do a MRI scan to see whether there is any cavernosal fibrosis, and I may consider cavernosal biopsy to confirm the fibrosis, to decide on penile processes after counseling the patient.
Right. Any time periods when you would sort of, which you would also add on? Yeah.
Patient present after 48 hours, because roughly after 36 hours, the permanent injury starts. So if the patient present after 48 hours, and ideally it's after 72 hours, we should consider processes rather than shunting.
Right. So when you're taking the, just a couple of words before we wind up, before you're taking the patient into theaters for a sort of a distal shunt, counseling wise, what are the things that you speak of?
So I will explain the procedure in detail, the alternatives and the success rate with the possible complication. Yeah. And then rather than this, apart from this common surgical, the anesthetic complication, I would tell there would be bleeding, bruising, and then subsequent erectile dysfunction.
Right.
And
fine. Okay. So that's fine. So yes, I think Taha, you covered most of it. In the pathophysiology, you did mention quite nicely about the mechanism of how papaverine causes the erection, etc. I would use the word compartment syndrome also, because it is a compartment syndrome that the priapism is defined as. And you mentioned about the arterial insufficiency in especially the distal aspects, while there may be high flow aspects in the proximal aspects of the penile vasculature, and also the venous occlusion and the venous dysfunction, right? That also can be mentioned in the pathophysiology. Evaluation wise, I think you mentioned about etiology, etc. And in this man, you may mention about a pelvic examination just to rule out any pelvic malignancies, etc. But it's a very unlikely mechanism, but just go through and mention those. The blood gases you dealt very well. And about the aspiration, irrigation, and these things you mentioned, I think almost all the factors. I cannot remember anything sort of that you specifically.
I forgot to tell the penile blocks that I would aspirate after the penile block.
Yeah, you mentioned penile. I think, yeah, when you're doing the shunting, you mentioned about the penile block. Yes, some sort of anesthetic, either circumferential anesthesia, or because some of these, as you correctly said, is done in the A&E or even in the ward setting, you can do these. And also, if you can specifically remember the dilution methods, etc. I mean, how much you dilute in 50 ml, and then you take 1 ml. That gives you 100 micrograms of this, and then you can keep on going every 5 minutes, etc. So that maybe, you know, it just shows that you are kind of doing it and you are ready for this practicality eventually, right? Yeah, and then to carry on with the distal shunting. And the guidelines do mention, before getting on to proximal shunting, about these tunneling procedures where you kind of take a 8 French, even a Hagas dilator, and then you push it right into the corpora cavernosa, and you dilate the system, and hopefully you will create a shunt, a much more efficient distal shunt. Actually, you can, if there is significant, because if you make, for example, put a 8 French dilate and dilate through the glands, you may have bleeding continuously from the glands wound. So without actually going very deep, you can just suture up the skin so that you don't catch the corpora cavernosa beneath, but you can just close up the gland skin so that you won't have persistent bleeding afterwards. So apart from that, I think you covered everything, and I'm happy that you mentioned about in the counseling the fact of erectile dysfunction, because otherwise, if you do not tell these patients, you know, they are coming with a massive erection, and they will say that I came in with an erection, you did a distal shunt and left me impotent with erectile dysfunction. So these are things that you have to document and put down on paper, saying that you have explained to them that the disease itself has a high chance of causing erectile dysfunction. Anything else that anybody else can contribute and add on to refine this?
So you ask about the when we give the renal ephrin, what would you look for?
Sorry?
You asked
right.
me.
Yes. Yeah. I mean, initially when you put this, it's a dark blackish kind of blood that keeps on coming out when you're aspirating, etc. But the color also will change to better once the ischemia is settling. And also, as you correctly mentioned, there will be some detumescence which you hope will remain so. I mean, that is what you're looking for at that point when you're doing the irrigation and the aspiration and installation of the sympathomimetics.
And thus I could have told that before shunting, because patient being settled in the ward, I could have assessed his baseline erection. So for documentation and follow-up, would it be
baseline erection in a sense? Right. You mean what kind of erectile dysfunction he had or not before?
Yes, sir.
Yes. Fortunately, in this man, of course, he's a diabetic who is getting papaverine for erectile dysfunction. So fortunately, it is probably documented. But as you correctly said, from a medical legal viewpoint, it's always good to document those and also explain to him that there is a very high risk of ED because of the disease, and that he understands that all this is being done to prevent that from happening in the future.
Okay.
Okay, I think that was quite comprehensive. Thank you. Over to you, Tirina and Niroshan.
Thank you very much, sir, for the 3 great case scenarios and the lovely feedback. So we'll move on to Dr. Niroshan Seneviratne. Sir, over to you. And the first candidate for you will be Dr. Munipe Villach.
Tilna, can you hear me?
Yes, sir.
Good evening, sir.
Good evening, Munipriya. Let me try to share the slides. Okay, can you see my slides?
Not yet, sir.
Can you see?
Not yet, sir.
Can you see now?
Yes, sir.
Right. Okay. Okay, Munipriya. So I've tried my best to do 3 questions, 3 to 4 questions, just to give you some idea on this regard. So let's go. Tilna, can you time the do the timing, please?
Yes, sir.
Yeah. Okay, Munipriya. So there is a 50-year-old man who presented to your clinic complaining of poor stream of urine for 3 months. How do you go about assessing this patient? What do you think?
The given history, the patient age is 50 and he's having the poor flow. So it is a lower urinary tract symptoms. There are so many causes for lower urinary tract symptoms. So most common thing in 50 is the prostate enlargement. But anyway, I want to evaluate the patients by history and examination to rule out the other causes such as urethral strictures, infection, and bladder dysfunctions, and the neurogenic causes as well. And for that, I will use international scoring, the validated scoring system, IPSS, to
Okay, right. So what you mentioned this term called LUTS. What do you understand by the term LUTS?
The lower urinary tract symptoms is mainly basically 3 components. That is the storage symptoms, voiding symptoms, and the post-micturition symptoms. So those symptoms we are calling the lower urinary tract symptoms. In the storage symptoms, the patient will feel frequency nocturia and frequency nocturia and the voiding symptoms is hesitancy, poor flow, intermittency, like that, and the post-micturation dribbling, and post-micturation symptoms is the incomplete evacuation as well as the term post-micturation dribbling. The voiding symptoms is the terminal dribbling, the post-micturation dribblings.
Okay, so what do you know about the relationship between these lower urinary tract symptoms and bladder outflow obstruction?
Due to the bladder outflow obstruction, the patients initially affect the voiding part of the symptoms. Then with the bladder outflow, the muscle, the physiological changes and the pathological changes will take place. With that, the patient is develop hypertrophy of the bladder muscles and the bladder function also affected. With that, storage symptoms will appear. So there is in blood outflow obstruction, the both storage and voiding symptoms is in blood outflow obstruction.
Okay, so what specific features you asked in the history about the LUTS symptoms, but what other specific features would you want in the history?
In history, specifically, I want to know the patient's past history and the past history regarding the instrumentation, the ICU admission with the long-term indwelling catheters, and the recurrent urinary tract infection, and the symptoms, poor urine stream, the 3 months duration, and whether this stream is progressively worsening or rapidly worsening, and what other symptoms associated with, and then for the look for the prostate and prostate malignancies, I would see for the general backache and other symptoms, those things, and the red flag signs like hematuria.
Okay, what about the drugs history?
Yeah, yes.
You want to ask any specific questions pertaining to drug history?
In drug history, the anticholinergics can cause the bladder paralysis. So because of that, I want to know about whether the patient is taking anticholinergics.
Right. So do you know any objective ways of assessment of his symptoms?
That is the International Index of Prostate Scoring System, IPSS.
Yeah, can you briefly tell me about the scoring and how you categorize these patients?
In IPSS, there is mainly two components, that is the symptoms as analysis and the quality of life as analysis section. In symptoms analysis, there will be a voiding symptoms and the storage symptoms, altogether 7. Each section will give 0 to 5 marks. And quality of life question will give 0 to 6 marks. And
which one is the most important of those two?
Symptom analysis is important to assess the severity of the blood outflow obstruction.
Okay. So what is the reproducibility of this test? So if you give this and another surgeon in the clinic gives the same question, and what is the reproducibility that it will give the same result? Any idea?
Yes, it is reproducible. That is a very important thing for this scoring system. That is a patient. Actually the questionnaire should fill by the patient. So because of that, the patient, we can assess the patient's the future, the treatment.
Yeah. Any idea how much percentage it will be the reproducible?
Percentage wise, I don't have any idea.
Okay. So what are the key areas you will look in the examination briefly? Key area.
Key areas. I want to rule out the prostate malignancy mainly. So because of that, I would look for the digital rectal examination to rule out any prostate abnormalities. And on abdominal examination, I want to see the palpable bladder and palatable kidneys, whether it's hydronephrotic, bilateral palatable kidney may be due to hydronephrotic. And on genital examination, I would look for meatus and the prepuce, whether the pymosis is there or meatal stenosis is there. And I would like to feel the urethra, any suspicious area of the urethral stricture. And general examination wise, the patient puffiness, which will give clue of the renal impairment as well.
Okay. So any pathophysiology of LUTS, very briefly? Why do people get LUTS?
Because of the prostate adenoma, hypertrophy of the prostate adenoma with the effect of dihydrotestosterone. So with the age, the
1.5 minutes.
Okay, let's continue another 2.5 minutes. Okay,
Okay.
just think with 10 minutes. Okay, right. Okay. Do you know any receptors related to the Lux symptoms? Any specific receptors?
Yes, sir. In prostate, the 1 alpha A receptors and the 5 alpha reductase receptors is there, and the bladder M3 receptors is important.
Okay. So do you know any association of Lux symptoms with any other diseases? What other conditions this patient might have?
Overactive bladder and the bladder outflow obstruction is most commonly associated to entities.
Okay. Do you know any percentage of that?
About 30% of overactive bladders.
Okay. Any other diseases? Okay. So this patient's IPSS is 10, quality of life is 4. Okay. If this patient was have to have a benign prostate enlargement, what is the roughly percentage of this patient at 50 years, you think?
At 50 years, by looking at the IPSS and the quality of life scoring system, I can't say exactly what percentage is benign or not. With the prostate size and the PSA is important to decide the percentage of benign disease.
Okay, what biochemical investigation would you do in this patient?
Biochemical investigation wise, I want to do the renal functions, creatinine level and the electrolytes, and because of the patients, the life expectancy is more than 10 years, I would do the PSA test after discuss with the patient.
Okay. Do you do any radiological scans for this patient?
Yes. Basically, I want to do the ultrasound scan of the kidney, ureter, bladder, prostate, and the post-voidal residual volume.
What will you specifically look at?
Ultrasound scan, I want to look for upper tract dilatation and the bladder wall thickness and the diverticuli and prostate size. In prostate size, rather than the prostate size, interprostatic protrusion as well, I want to see. And after that, the prevoidal volume and the postvoidal volume.
Also, would you do a TRUS scan in this patient? Would you do a TRUS scan?
Transabdominal versus TRUS scan, the difference between those two, the accuracy of the prostate volume is better in TRUS scan, but if we can get idea about the prostate volume through the transabdominal scan, in that sense, I don't want to do the TRUS scan again, because I will assess the patient with the PSA. If necessary, I would go for a TRUS guided biopsy if indicated.
Okay. What is the place of uroflowmetry in this patient?
In this patient, the IPSS is 10 and the quality of life score is more the 4. So in that thing, this patient is more chance to have the blood outflow obstruction as well as the overactive component of the bladder. So in that case, the uroflowmetry will give more details about that. So it is important in future management of this patient, especially the surgical management.
What advice will you give when you are doing a uroflowmetry specifically to the patient?
If I do the simple as a simple urodynamics in uroflowmetry, I want to specifically mention the patient minimum of 150 ml volume of urine patient should pass during the study. Otherwise, it would inconclusive. We can't comment on that.
Okay. What do you look in the flow tracing?
in flow tracing, I want to see the voided volume, maximum flow Qmax, and the average flow Q average. And
so this patient's flow rate is here. Can you comment on this?
According to the given the pattern of flow, it's more likely to have the stricter disease rather than the blood outflow obstruction, because of the sawtooth appearance is there, and the maximum flow is very low, as well as the average flow is 3.7. So it is inadequate. Voided volume is adequate to comment this.
So what is the significance of Qmax in this study?
Yeah. It is Qmax is 8.2. So rather than go through the average flow, the Qmax will be benefit to manage in this particular patient.
Okay. I think time is up, isn't it? There are a few more questions I want to do in a rapid session. So anything you want to ask, anyone want to ask about the questions? I think this is a basic question here. I think you did fairly well. Only thing you need to be more specific depending on the question. I've just broken down because sometimes they might give as an open question. So then you have to organize your thoughts. So you answered here all right, but be more specific when you know the storage symptoms and the voiding symptoms don't have much pauses. So straight away, you must be able to rattle off those symptoms. Then the relationship between LUTS and bladder outflow obstruction, you have to know about the Hall's rings. You know the Hall's rings? So
yes.
there is only overlap of these symptoms.
Yes.
And then certain symptoms are not related to bladder outflow obstruction per se. So that's what you have to highlight there. When you have specific features, so you need to tell about the medical and the surgical history and also the drugs, which is important. So you touch upon that. And don't forget the drug history.
Okay.
Then the objective way of assessment, you can talk, there are many scoring systems, okay? Not without limiting to IPSS. So there are many scoring systems, of which the commonest which we use is IPSS. So you can say that. And the reproducibility of this test is about 95%. Okay, that is the good thing about this. And more important than the severity of the symptoms, the quality of life is the one which will determine the treatment option, investigation and treatment. Okay, so that you have to highlight. The severity of the symptoms is important when you put on a treatment to see how they respond to that treatment. So the key areas of your examination is very simple: general examination and specific examination, which you looked at. You came to the general examination last and told about the renal impairment. That's okay. But then pathophysiology of LUTS, I think you would have read. Just to briefly, you have to know that this is a dysregulation of the receptors in the prostate and in the bladder, and also the atherosclerosis. Those are the two mechanisms responsible for lower urinary tract symptoms. So just briefly read up on that, because these are the ones for atherosclerosis causes a little bit of a chronic ischemia. And because of that, there is a denervation of the nervous system, hypersensitive system. So that's why certain LUTS symptoms coexist with overactive bladder, you know.
Okay.
So that's why the irritative LUTS sometimes do response to certain drugs. Okay, so just briefly read about that. Okay. Then the receptors, you have to tell about, well, you touch upon the alpha receptors and the muscarinic M receptors, and also the adrenergic beta receptors also you have to touch upon. Okay, the association of lung symptoms is, yes, you have to know about these symptoms associated with erectile dysfunction, ED. Okay, so ED is associated with that. Certain patients have hypertension. So because the pathophysiology is, one part is atherosclerosis, so atherosclerosis diseases coexist with this. And also the bladder over and underactivity. So those are the things you may have to check in this patient before you start treatment. Okay. So when they can give these symptoms. According to that, you may have to categorize them into mild, moderate, severe symptom disease. So if you know the natural disease progression, roughly they give like usually 40 to 50, 50 to 60, 60 to 70, like that. So go on a 13%. It's difficult to say what percentage. So roughly the percentage is about 13 to 15% in 40 to 50 group patients. If you investigate, you can find BPH. Okay, so go in a rule of 13%. Okay, not clearly, but the certain studies have shown. So go 40 to 50, 13. Okay, so 50 to 60, 26, like that. Okay, so if you give a rough range between that, that's okay, right?
Okay.
Biochemical investigations you told, so you forgot about the UFR. Okay, don't forget the UFR. Okay, basic test. Okay, UFR, renal function, and PSA after counseling. Those are very quick 3 words you have to tell. And radiological scans, you were told that ultrasound scan, but don't forget the post-vital residue. That is the important thing, which will determine what type of treatment you are going to put for this moderate symptom patient. Then trust is only indicated if you are going to do a biopsy. Okay, so it's not a first-line investigation. Uroflowmetry is important so that you objectively assess his, because he's moderately symptomatic, and quality of life 4 means he's not satisfied with his current status, isn't it? So you want to have a baseline of his uroflow, and also to determine the treatment response. What the advice when you give this test is, so basically you have to come full bladder, and don't when you pee, don't compress and squeeze the penis. Okay, so that you get the artifact which is there in your uroflowmetry. That's what I want to show you. Right? It looks like a stricture, but it is not a stricture. So that's where patient doesn't pee properly into the funnel, right? Okay, so you will look at the voided volume, then void in time. Okay, you know all this. Okay, just tell these are the basics. Okay, the flow time. Okay, normal flow time is looking is less than 40 seconds, so it's more than that. Okay, and the flow pattern.
Okay.
Okay, right. Then okay, so other things what I wanted to touch upon, that we'll take with the next candidate. Okay, is that all right?
Okay, thank you very much, sir.
Yeah.
Okay. Next candidate is going to be Dr. Nishant Lianapathirana, and yeah, over to you, sir.
Hello, Nishant.
Hello, sir. Hello. Good afternoon.
I don't think I will have much questions to start off, so we'll just continue from where we were. You were there, right? You were listening to it, right?
Yes.
So what do you understand about bladder outflow obstruction index, and what was the relevance into this patient?
Bladder outflow obstruction. Yeah, bladder outflow obstruction index is a finding that a result that we can get from the uroflowmetry. It is a part of the pressure flow study. So in the voiding phase, we can measure the PDET at Qmax, and we can plot it against the Qmax. And then we can make a nomogram, which is called ICS nomogram. So we can see whether the patient is patient has a urodynamically proven obstruction or bladder outflow obstruction.
Okay. What is the place of cystoscopy in this moderately symptomed patient? Would you do a cystoscopy for this patient?
Well, I would do a cystoscopy or a flexible cystoscopy if there are red flag signs, for example, visible hematuria or recurrent UTI. And also if the history is quite suggestive of a stricture disease, like a past history of pelvic fracture or STI. Otherwise, I wouldn't do a routine cystoscopy for this man.
Okay, right. Okay, we'll go to the proper question now. We got this patient, his PSA is 1.5, prostate is 30 grams, okay? And when we discuss with the patient, he decides to do watchful waiting, okay? Right? What are your thoughts about this?
Okay. So this is a 50-year-old man. Natural history of the BPH, if the patient is having BPH, about 1/3 of patients will improve and 1/3 will stay the same and 1/3 will deteriorate. There are signs or there are some features which will suggest the progression of the disease. So the age is one. So this patient is having around 50 years of age. It's not much of a concern. And IPSS score above 7 is considered as a sign of disease progression. Of course, the quality of life is quite poor. So that's a negative sign for a watchful waiting. PSA cutoff is 1.4. If it is above 1.4, it's a sign of progression, and prostate size is around 30. So it is marginal for this man. All in all, we can give a trial of watchful waiting, but he's leaning more towards medical management as far as I think.
Do you know any studies relevant? I think you mentioned those parameters quite correctly. So any studies relevant to these observations?
I think it's Olmsted County study, which has.
Yes. So what advice will you give him if he's not willing for any medical therapy?
Then I would first counsel him about the condition, explain the possible etiology of what he's having, and then I would reassure him this is not a cancer if I do the PSA and the rectal examination. Then I would advise him about the lifestyle changes, which include fluid intake. So I would specifically advise him to sort of just drink to his thirst and don't do any over drinking to improve the urinary health, and avoid some of these bladder irritants like caffeinated drinks as well as the fizzy drinks. Yeah. Also, I would tell him about the time voiding and regular exercises.
Okay. So well, you talked about the natural disease progression markers already, so we'll skip that for the moment. What complications is he at risk during watchful waiting? What risk?
Well, he has about 2% risk of going into acute retention in the long term, and he has about 10% chance of well, it's not a complication. So retention is the main thing. Yeah.
Right. Okay. So what are the indications to start drugs on him? Well, you touched that the progression disease markers. Okay.
Yes.
Any other things you think the indications for? What is the real indication to start drugs on this patient?
Particularly on this patient is actually the quality of life score.
Yes.
Which is 4.
Yes.
So bothersome symptoms.
Yeah. So that's the main indication to start drugs on him. Okay. So if you were to start on monotherapy, what is the best monotherapy you want to start?
There are several categories of drugs which we can start. They all are alpha blockers, And there are uroselective alpha blockers, which includes alpha-1A receptor blockers. And the currently used drugs are the tamsulosin, which is selective alpha-1A blocker, and also I'm aware about the silodosin, which has shown a much more affinity to alpha-1A receptors.
Okay. So what is the mechanism of action?
Alpha-1.
What is the mechanism of action?
So, yeah, alpha-1A receptors are abundant in the bladder neck area as well as the prostate. In BPH, there are two components which contribute for the blood outflow obstruction. One is the static component as well as the dynamic components. And static component is basically coming out of the stroma, and the dynamic component is the prostatic smooth muscles. And these receptors are abundant in prostatic smooth muscles, alpha-1A receptors. When you block them, that will cause smooth muscle relaxation, which will address the obstruction by the dynamic component.
Okay. So what are the common side effects you will tell this patient?
Most of the new generation drugs are much more selective, but they can still have vascular side effects, which includes postural hypotension. So I would advise him about this and advise him on signs of postural hypotension. Other than that, that can give rise some patients that can cause nasal congestion, and in some patients that can cause some asthenia, and also most commonly about 70% of patients will have retrograde ejaculation. This is a young man, so I'll have to warn about the retrograde ejaculation.
Right. How do you assess the response, and how long would you prescribe the drugs to see whether the drugs are acting upon him?
Yes, I think the action will start within about 3 days' time. But I would ask him to continue the drugs for at least 6 weeks, and then I'll reassess him after about 6 weeks to 2 months' time, and see whether his IPSS score is improved. So about 4 points improvement is considered as a significant improvement. And then also the quality of life border score, whether it has improved or not.
Right. Okay. So if any advice if he's undergoing any eye surgery?
Yes, one of the side effects of the alpha blockers or alpha-1A is the floppy iris syndrome. So I would ask him to tell the ophthalmologist about the use of tamsulosin, which can be temporary stopped, and for that period of time he will have the symptoms recurrence. I would have to tell him about that.
Okay. Okay. When will you start combination therapy in this?
Combination therapy is indicated in moderate to severe LUTs. So I would assess his IPSS score, and also the signs of progression, and the most importantly, the prostate size. So, so if there's a moderate to severe LUTs and prostate size above 30 to 40, 40 is the usual cutoff. So I would consider about the combination therapy with a 5-alpha reductase inhibitor.
Okay. So what is the action of finasteride?
Finasteride is a 5-alpha reductase inhibitor. So the active form of testosterone is the dihydrotestosterone, which is the testosterone is converted to dihydroxy by the 5-alpha reductase. So dihydrotestosterone is known to cause the prostatic stromal proliferation in the benign prostatic hyperplasia. So finasteride is going to block that, and both, there are two types of 5-alpha reductase, type 1 and type 2. In the prostate, it is mainly the type 2. So finasteride will block the type 2.
Okay, right. So what are the common side effects you will tell if the patient is on 5-alpha reductase?
Yeah, the common side effects of 5-alpha reductase include around about 8 to 10% will get erectile dysfunction, and about 6% of patients will have loss of libido. And those are the two common things. And I would mention about the possibility of having a high-grade prostate cancer, as it is mentioned in the FDA, that if you are prescribing, but there is a small remote chance of having a high-grade prostate cancer in the long run. Yeah, those are the side effects I would mention.
Okay. Any trials you know about combination therapy works better?
Yeah, the MTOPS and the combat trial.
Combat trial, yeah.
Yeah,
okay.
Those
okay.
shows the evidence. Yeah.
Any other groups of drugs you think this patient would benefit?
Yeah, for this patient, I think if there are any history of storage components, storage LUTs, including the nocturia, he will benefit from a combination of anticholinergics, and there are two common trials, which is actually the TIMES trial and Neptune trial, which has quite nicely proven the place of anticholinergics, and it is safe, and yeah, we can add that one. And the other group of drugs, which is newly came to the guidelines, are the PDE5 inhibitors. If there is a concomitant erectile dysfunction, we can start 5 mg daily PDE5 inhibitors after excluding the contraindications.
Any other drugs?
Mirabegron? Yeah, yeah, mirabegron can also be combined with the 5-alpha reductase.
Okay, time up. So I think Nishanta, I think you did all questions well. I think you covered most of the things. There was hardly anything for me to tell. Anything anyone want to ask? So I think you nicely told that the markers of the disease progression, you know, the PSA and the prostate size, and the other thing is the Qmax. Okay, if the trial shows Qmax, if it's less than 12, then is a marker to not to do watchful waiting and counsel your patient to start on drugs. So those are the markers that we'll see that the patients will respond to the drugs. And you quite correctly said you will look at the quality of life when the patient comes back. That is the most important marker to check. And also the improvement in the IPSS score in points of 4. Those are the things to mainly look at. And in terms of adding 5-alpha reductase inhibitors, you would want to see the prostate shrinkage, isn't it? So if you generally, but it is a long-term thing, you know, you have to wait for long-term, at least 9 months to 12 months, and you will see at least a 20% regression of the prostate. That is the one, you know, that 5-alpha reductase has worked. So you have to give it in the gland size is more than 40. Otherwise, you won't achieve that. I think you covered everything, Nishant. Nothing much for me to say.
Thank you, sir.
And mainly the mirabegron, no? That also, especially to increase the bladder volume, you know, when they have small volumes with increased frequency, these drugs works better in those patients. Okay. All right. Shall we move to the next question?
Yes, sir.
Or time up?
No, sir. We can go on to the next candidate. We have another 20 minutes.
Yeah.
So Dr. Hillary will be the next candidate.
Okay. Hello, Hillary. Can you hear me?
Yeah, I can hear you, sir.
Okay, so there's a 60-year-old man with IPSS score of 20 and quality of life 4. He has taken oral medications for 1 year, but he's not happy. What can you offer him?
So this 60-year-old man is having severe low urinary tract symptoms with unsatisfactory quality of life with medical therapy. So he is going to need surgical options. of bladder outlet procedures. His prostate size was, I would like to know the prostate size of this patient.
Okay, so you think he needs surgery, okay? Right. Yeah. You're correct that you need to know the prostate size. Imagine the prostate is 65 grams, okay? Right. Sonographically. So what are the indications for the TURP generally?
In general, recurrent and relapsing urinary retention, recurrent relapsing bleeding with the prostate, bladder stone, and poor lower urinary tract symptoms, poor response to medical treatment, and high pressure chronic retention, renal impairment with the prostatic enlargement, and yeah.
Okay. So how would you specifically consent this patient for surgery? Looking at the explaining the possible complications briefly.
Yeah, so I will explain the procedure in detail that I'm going to resect the prostate endoscopically, and the complications, the immediate or the early complications, which can either be related to anesthesia or the procedure. The anesthetic complications are the ischemic events that can happen, and then the deep vein thrombosis and other complications related to the spinal or the general anesthesia that's been used. Then the procedure-related ones are the bleeding, the primary.
So you prefer a general anesthesia or spinal anesthesia?
I prefer a spinal anesthesia generally because that will help me identify the features of TUR syndrome early in the spinal anesthesia.
Okay, go ahead.
Otherwise, I have to just rely on the hypertension and tachycardia, which is a late sign. And then the complication-wise, the hemorrhage and requirement for transfusion, which is about 1 to 2%, the sepsis and systemic sepsis and urinary tract infection, which is about 3%. And then the transurethral resection syndrome, which is a dilution of hyponatremia and fluid absorption and glycine toxicity.
What is the mortality, 30-day mortality after TURP?
It is less than 1%.
Less than 1%. Okay. All right. Okay, so these, what else you want to tell?
So in the long term,
yes.
Yeah, the incontinence, urgency.
What is the chance of incontinence?
The permanent incontinence is again around 0.5 to 0.6%. The urgency related incontinence is around 0.7, less than 1%. And then the annual decrease of lower urinary tract symptoms, which is about 2%, and he's going to need a redo operation maybe about 8 to 10 years down the line.
Okay, so what are the key steps when you're performing the TURP? What are the key steps? Not in detail, what are the very key steps you want to look into when you're doing the TURP?
Yeah. So the cystoscopic assessment to see whether there is the urethral or any other bladder pathologies are available there, which I need to treat. And then insertion of the resection. And resection could be the monopolar or bipolar. And I prefer monopolar. And then the identification of any complications related to the procedure, and if there is any features of TUR syndrome, then to wrap up the procedures as fast as possible to achieve hemostasis, and to go up to the capsular fibers, and then to create an adequate channel, and then achieve hemostasis and come out. The landmarks are the verumontanum and resect the tissue above that and
Okay.
achieve hemostasis. Yeah.
Okay. So what blood vessels you need to control during the surgery? What are the main blood vessels you want to control during the surgery? And how do you do that?
The artery of the flux and the bedenox. The arteries of the flux, they are in the if we take the clock phase from 11 o'clock to 1 o'clock, the artery of the flux supply the prostate, and then the bedenox 5 to 7 o'clock region. So I prefer Plandy's technique, and I resect the median lobe first, and then I'll control the bedenox first, and then start at 1 o'clock and control the one side of the flux first, and then resect that lobe, and then come to the other side to minimize the bleeding.
Okay, great. What is TUR syndrome?
So it's a symptom complex related to dilutional hyponatremia and fluid overload and glycine toxicity. When you use 1.5% glycine for resection, then the other ones are the mannitol and 5% dextrose and water. We use water, sterile water commonly. The incidence is variable depending on the size of the gland and the duration of the resection, vascularity, various other components. When the gland is less than 5%, 45 grams, the given incidence is around 0.8%. And it increases to about 1.5% when the gland size is more than 45 grams.
Okay. Okay. So what time frame can it develop post-surgically?
Usually the given time period is about 60 minutes for the standard TURP procedure, but it can develop anytime. I've seen it developing from 15 minutes. Depends on the vascularity, depends on the intravasation. Usually 20 milliliters per minute is the absorption rate given, but it could vary depending on vascular prostates, the inflammatory conditions, and if the water column is high, then more fluid can get absorbed.
Okay. So what is the main pathophysiology behind this TUR syndrome? You initially told that it was a dilutional hyponatremia. Yeah. And what else? What are the key elements of the pathophysiology?
Then the hypervolemia or the fluid overload.
Okay.
And then the glycine toxicity when you use glycine 1.5% for the resection.
Yeah. Have you used glycine?
Yes, in my overseas training.
Right. Okay. So what steps you can take to minimize this step, pre-op and peri-op?
Yeah, pre-operatively, I'll see what is the sodium level of the patient, and I'll correct the hyponatremia, and then I will keep the fasting to a minimum, and I'll correct hypertension and the other correctable factors. And during the surgery, I'll make sure the water column is, the fluid column is probably less than 60 centimeters from the patient, just as adequate for me to achieve good visualization. And I'll use Iglesias continuous resector scope to keep the bladder under low pressure continuous irrigation. Then I will stop my resection at the capsular level without perforating and perforating into the venous channels. So that will minimize the fluid absorption. And if it is so, then I'll try to quickly achieve hemostasis and come out and start the irrigation.
Okay. Time up?
10 minutes, sir. Yeah.
Yeah, okay. Okay. Treatments. Okay, I'll share the other questions if you want because of the time things. Okay, so basically, Hilary, you these are basic things, so you did well. Okay, so the consenting you have to touch upon the procedure related complications and also the failure. You did touch upon the chance of the failures, stock failures also, which can vary from 4 to 6%. Depending on the bladder dysfunction they have. You explain very well the possible complications. And now when you talk about the key steps performing TURP, I mean, you just have to, streamline your answer. You know this, but when you want to answer, so quickly the positioning, then you have to ensure that the urethra is of adequate caliber so that you dilate if necessary. Then once you put the cystoscope, surveillance of the bladder, assess the size of the prostate, landmark Veru, then start on resecting. You did well to tell about the blood vessels. So basically you're targeting those blood vessels so that you resect initially the median lobe, okay, and then the other lobes accordingly. So just streamline your thoughts when you're telling, but so that was okay. And TUR syndrome, now it is becoming less because of the use of saline and Turis, but you have to, they will probably ask about this. The incidence is becoming less and less. But the main thing is perioperatively not to breach the capsule, okay, and to early identify this and make sure that it can be prevented. Then pathophysiology, well, you told about the fluid overload and which will lead to cerebral edema and the AKI. That has to be touched upon. Minimizing, you told the things to do pre-op and perioperatively. Don't forget the irrigation fluid, the type of fluid, the height of the fluid, how or if it's through a flow pump, the speed, all that is important. How to diagnose a TUR syndrome? Well, I think you just have to read about that. And these are some of the things you have to know. They will probably ask what alternative things you can do to treat large volume disease so that you can touch upon, depending on the availability, the enucleation techniques using the conventional urethral method or urethral resection methods or laser you can touch upon. And just about some brief things about the laser they might ask, but I doubt that they will go into detail on this. TURP will be the one they will ask. And any questions you want to ask me or anything else?
Now, when you discuss about the prostate, the TURP, should we mention about the consent, positioning, WHO checklist, COVID check, or things like that?
No. So the thing is, now you need to be very specific, okay, you got only 7.5 minutes, right? So what is important for you to is to be your answer precise, but cover much as areas possible. So don't go to generalized things, probably, checking COVID and everything, they are not going to check in this exam, You understand? So just, they probably
Excuse me,
want
sir.
Yeah, go ahead.
Munipriya, sir, you have put one question. What time frame can TUR syndrome develop post-surgically?
Yeah.
So what is?
So the TUR syndrome can go up to 24 hours. Okay,
Okay, sir.
So that's why it's important when you I mean, I don't know whether Gobi or Anuruddha is there. Now, because of using the saline, we hardly any see TUR syndrome, but we see mild symptoms post-op in the wards. Okay. So these patients develop a little bit of hyponatremia, a little bit of confusion. Okay. And that is because of we've done a deep resection. The capsule has been breached. The venous plexus have been opened, but not a big problem, but you need to identify. So the TUR syndrome can go up to 24 hours. So
usually up to the irrigation time, no?
Yeah. It can vary up to, so you need to keep a close eye during that period. Okay. So it can start, within 15-20 minutes immediately once you open up a venous channel, and then it can go up to 24 hours to, I mean, we hardly do irrigation now beyond 24 hours unless it's a very, massive prostate. So that's the answer for that question. Anything else?
Thank you. So this question, when will you decide not to do a TURP?
Yes.
Is that if you see a large bladder stone, large bladder tumor, is that what you expected or something else?
Correct.
Or
those are the things you have to tell, right? So straight away, if the patient scan showing a bladder stone, okay, well, we most of the time, if it's a small stone, we can do the stone and deal with the prostate. But if it's a big bladder stone, we will deal with the bladder stone first and then plan for the TURP on a later date, So those are the things you have to tell that you will not decide to do a TURP. Okay. And the other thing is the gland size, generally the teaching is if it's more than 80, you will not consider for a conventional TURP, but then you will resect only one lobe, go as a stage procedure. But then think of alternatives like, enucleation techniques. All that comes into interplay. That was the question. That was the answer I was expecting. Anything else you want to ask me?
The last one, the latest models of treating prostates, that's HOLAP and enucleation, minimally invasive.
Minimally invasive. Yeah, you need to talk about a little bit of urolift, okay, fresium, aquablation, then prostate artery embolization, okay.
Yes.
These are the other options available, okay.
Okay.
What are the... So anything else you want to ask? Then the last question I had was retention patient. Okay. So if a patient comes in retention, okay, these are the things you have to know whether it's acute retention or acute on chronic retention. So differentiation of that is important. Okay. It's pretty simple clinically. You will know the pain and the bladder, whether it's a painful bladder or a percussible bladder. That is important. Then definitive management is, catheterization. And okay, anyone want to comment what is the chance of acute TOC failure following a patient going for after acute retention within 1 month and 1 year? Any idea? So there are unfavorable factors. You have to look at the prostate size, the IPP, and the bladder wall thickness. If these three factors are there, the chance of you having another retention within 1 month goes up to about 30 to 40%. So within 1 year, it can go up to 70%. So generally, what they say is if you have one cohort of patients retention coming, only 1/3 of patients will bail out with medication. So other people will have to undergo surgery. But mind you, this is spontaneous retention, not precipitated retention. So those are the things you have to have some idea to, and then also to remember that even when you have acute retention, if you operate on a large series, the chance of patients having a failure to void is about 8 to 10%. So they will have some degree of bladder dysfunction, which will contribute to that. So these are important in the consenting process if they ask. Okay. Then a little bit of HPCR. I think everybody knows that, no? Anything else you want to ask me on HPCR? How long it takes the GFR to come to normalcy? Anyone?
So it takes 3 months because glomerular function returns to normal in 3 months, whereas tubular function becomes normal in 2 weeks, like after.
Yeah. Hang on, I lost my slides. What happened to my slides? Okay. Anyway, any questions you want to ask me?
Would you please repeat the risk factors for recurrent irritation, sir, please? You said the
Okay.
IPS.
Sorry?
Recurrent episode, risk factors for recurrent retention or failure to walk after retention, please?
Yeah, so if they have an intraprostatic protrusion, okay, significant intraprostatic protrusion, large gland volume, okay, associated with the IPP, and also the bladder wall thickness, okay.
Thank you.
So these signify strain, isn't it? The bladder wall thickness is generally around 3 millimeters, but if you have very significant, and the PVR of more than 100. Those are the markers of that this patient will have another TOC failure. Okay. That means once the patients you give adequate time and then give a TOC, then subsequently you do the simple urodynamics, which is the uroflowmetry and the ultrasound PVR. And if these features are there, they will probably have a higher risk of getting another retention. So those patients have to be counseled to undergo surgery.
So 1/3 will come in 1 month time, and another 1/3 come in 1 year time. That's
roughly it would say. These observational studies, they say roughly. Okay, so they say about 1/3 of patients will be okay. They will probably not come back to you with they'll probably be all right with medication.
And can I ask you?
Sorry. Carry on.
Sorry. Now you mentioned about 8 to 10% increase in risk. I could not follow what it was. Now, immediately after the talk, I think it's probably the routine catheterization, or what was that statistic about?
No, the patients who develop retention, okay. Now patient comes to you with retention, acute retention. Then you give a trial without catheter. What is the chance of the patient getting the second retention?
Yeah,
how would you decide? Fine. How would you decide whether this patient will get a second retention? What are your markers?
Yeah, that bit's fine. Now, after that, you mentioned there is a 8 to 10% risk of developing.
That is post-URP retention.
Post-URP retention. Yeah. Right. So what they say is, if you have a patient with acute retention, the chance of even the TURP failure is about 8 to 10%. And it can go up to 30% if a patient comes with acute on chronic retention. So it's very important to identify those people with acute on chronic, so that otherwise people's expectation is you want to prevent him without a catheter, isn't it? But they will probably end up in long-term catheterization. You understand? So that I didn't go to that question. Then the next question to ask, how you do manage that those patients is either you have to teach them CIC, or sometimes, because it's a long-term catheter patients, then they will need a SPC. Those are the two options you give when you answer.
Okay, thank you.
Anything else?
Fluid replacement rate after post-obstructive diuresis. Some say 90% of previous output, some say 50% oral IV. Is there any consensus?
Well, it's difficult to judge. Depends on how much volume you want to replace. Okay, so initially, if it's initially you don't want the patient to go to AKI. So initially you would start on volume to volume replacement initially, and then you will reduce the volume accordingly, looking at the state. But then there are certain patients will pass about 50-60 liters per day. Then are you going to volume replace? So generally, what you do is, if the urine output is per quart hour, if it's less than 100, you replace volume to volume. If it's between 100 to 300, you reduce 25 to 50 mils. And if it's between 300 to 500, you reduce about 50 to 100. Did you get what I said?
Yes.
Yeah. So you titrate accordingly. So there is no hard and fast way of doing it, but make sure that our concern is the patient going to AKI, isn't it?
Niroshan, you ask all the difficult questions today so that you can ask simple questions on Tuesday.
Yes.
He's Anuruddha.
So any comments from your side, sir? I didn't know that you
No,
were there.
all very, very nice. Thank you very much, actually. Excellent, this thing. I think they also answered very well. The candidates also, I think they are on the ball. I think all of them will pass.
Yes. And it won't be such difficult, according to Anuruddha, sir.
Day one consultant, no, Niroshan.
Yes.
I didn't know any of these things when on day one.
Same here. Yeah.
That's the thing. So you have to pass everywhere.
Yeah. Anyway, I wish all of you all the best, and hope to see you on Tuesday. Okay.
Thank you very much, Niroshan.
Yeah. Okay.
Yeah.
Thank you.
Thank you very much, Dr. Niroshan Siniviratne, sir, for those lovely case scenarios. I think they were very informative, and all of the candidates would have benefited significantly from them. Although it's a very common topic, there are a lot of areas that, as the discussion went on, we realized that there are a lot of small nitty-gritties that are needed to fill our gaps in knowledge. So thank you very much for those scenarios. And thank you again, Professor Ajit Malasekara, sir, for your case scenarios, and especially the advices on timing and how to get through the exam. So I think all these last minute touch-ups will be very valuable to the candidates. So with those, we conclude the Uromet 20, and I think this will be the last official session before the exam, which is going to be on Tuesday. So I think a lot of people contributed significantly to these sessions, and I think the candidates would have benefited from all of that. And special thanks should go to Dr. Anuruddha Begunasekara, sir, and Dr. Balagopi for all their tireless efforts throughout this all these sessions and in between sessions as well, and Dr. Nishant Nilapatana also for all the organizing of these. And also, I would like to thank Sipla as well as the Slaus for organizing these sessions, and for I think these sessions will be beneficial not only for these years but also for all the candidates even in the future. And sometimes maybe as these are available in YouTube and all, maybe in other countries as well, because these are very good sessions and lot of valuable inputs from experts in the field recorded in these. So without taking further time, I would conclude this session. Thank you, everyone.
Thank you, Tilina. Thank you, Tilina. Thank you very much for being the anchor person. Did a wonderful job. It's not easy to coordinate with all of these people who are very busy. You did a wonderful job, and thank you very much. I think all of you have brought the Sri Lankan urology to a very high level with these Uromets. And as Tilna said, recordings are there, will be beneficial for all of us. And for the trainees to come, registrars, senior registrars, I think we should, all of us should be very proud of this project. And I also wish everyone all the very best and success at the exam. The more you pass, the credit will be ours, no, Tilina. Thank you very much. Good night.
Okay. Thank you very much.
Okay, well done.
everyone.
Thank you. Thank you.
Good night. All the very best to all of you.
Good night. Good night.